Thank you very much, Andrew, and welcome to all. My name is William Moss, and I'm the Executive Director of the International Vaccine Access Center at the Johns Hopkins Bloomberg School of Public Health. And it's my great pleasure to welcome you to this webinar celebrating vaccine victories, the EPI program at 50. So here at the International Vaccine Access Center, we have a vision for a world free from adverse health, economic, and social consequences of vaccine-preventable diseases. And so it's our great pleasure to host this webinar celebrating 50 years since the expanded and essential immunization program started. It's estimated that this program has saved more than 150 million lives over the past 50 years, and that has to be one of the greatest achievements of humankind. There's been great progress, and we're going to hear about that today in today's webinar, but there are also continuing challenges, and we need to step up and address these challenges going forward. I'm just going to note that today is also World Malaria Day, and so we can also celebrate the fact that we now have 2 vaccines against malaria. So I'm going to start off by introducing our speakers. We have 4 speakers today. Each will give a brief presentation. And I'm so thrilled to introduce 2 of my mentors, Professor Neil Halsey and Professor Matu Santosham, and 2 of my esteemed colleagues, Maria Noel and Chizoba Winodi. So Professor Neil Halsey is a professor emeritus in the Department of International Health here at the Johns Hopkins Bloomberg School of Public Health. He's also a professor emeritus of pediatrics at the Johns Hopkins School of Medicine and director emeritus of the Johns Hopkins Institute for Vaccine Safety. Neil has a long, distinguished career in vaccines and the prevention of vaccine-preventable diseases. He, and very importantly, links to the EPI program. He was on the research and development group of the World Health Organization and played a key role in the schedule for measles vaccines. Neil also served on the CDC Advisory Committee on Immunization Practices, the ACIP, and served on the Committee on Infectious Diseases of the American Academy of Pediatrics and chaired that for 4 years. And many of you may be familiar with the Red Book that comes out of this committee. Neil has conducted research on almost every vaccine, if not every vaccine, in the EPI schedule, and has a particular interest in vaccine safety. My other mentor, Professor Matu Santosham, is a professor in the Department of International Health here at the the Bloomberg School of Public Health, and a professor of pediatrics in the Johns Hopkins School of Medicine. Matu is director emeritus for the Center for Indigenous Health, which he founded, and serves as a senior advisor here at the International Vaccine Access Center. Matu has made enormous contributions to child health, and particularly with vaccines. He was seminal in the development of oral rehydration solutions and has worked also across a number of vaccines, including Hib, for which he led the Hib initiative that really accelerated the introduction of Hib vaccines across the world, but also pneumococcal vaccines, rotavirus vaccines, as you'll hear about today, and many others. Matu has received many awards, including the Albert Sabin Gold Medal Award in 2011 from the Sabin Vaccine Institute. My colleague Maria Noel is a research professor in the Department of International Health and the director of epidemiology at IVAC. She studies the epidemiology of vaccine-preventable diseases, focusing particularly on disease burden and vaccine impact. She studied a number of different vaccines and vaccine-preventable diseases, including meningococcus, SARS-CoV-2, RSV, and pertussis, but is really known as a global expert on pneumococcal disease and pneumococcal vaccines. She was a key member of the PERCH study that determined the etiology of pneumonia in settings across the world, and some of her current work that you'll hear about is focusing on serotype distributions of pneumococcal disease and the implications for vaccines. My other esteemed colleague is Dr. Chizoba Winoti, who's an associate scientist here at the International Vaccine Access Center and a Nigeria country director for IVAC. She's is director of immunization for the USAID-funded Momentum Country and Global Leadership Project. She studies immunization program delivery, implementation research science, behavioral science, and how immunization systems fit within the primary healthcare system. Chizoba is also very interested in civil society organizations and the role they can play in promoting vaccines, and founded the Women Advocates for Vaccine Access in Nigeria to increase vaccine uptake. She has focused much of her work in Nigeria, but has also worked in many countries: Kenya, Ethiopia, Tanzania, Madagascar, among others. So we will get started, and I'm going to turn this over to my colleague and mentor, Professor Neil Halsey.
Thank you very much, Bill. I appreciate the introduction. I'm happy to give a brief history of the EPI program. And as Bill mentioned, WHO is proposing changing the name to Essential Program on Immunization. Next. The EPI program was born out of the smallpox eradication program. D.A. Henderson, former dean of our school, led the eradication program. Next, Bill Fagey, who worked in the smallpox program in Africa and in Asia. He developed the successful strategy called ring vaccination for eliminating and then eradicating smallpox. His book, House on Fire, is a classic public health book I recommend that everybody read. Many of the West African smallpox eradication people did go on to other leadership positions. There's not time to mention all but one. Next slide. In West Africa, during the 1970s, the initial strategy was to vaccinate everybody against smallpox. In the villages that they were working in, the villagers complained that they're trying to vaccinate them against smallpox, but it was measles that was killing many of their children. And so they added measles vaccine. On the right-hand side, you see them giving measles vaccine in one arm, smallpox vaccine in the other arm to young children, smallpox vaccine to everybody else. Next slide. Rafe Henderson worked in West Africa. He became the first director of the EPI program, and amazing accomplishments. He's was an unassuming person and doesn't get as much credit as he should. He established the global management programs, standards for assessment of immunization coverage, including unique surveys in difficult to reach communities, and the recommended schedule, and then programs in all of the countries. Next. The vaccine against diphtheria, tetanus, and pertussis, or DTP, is the backbone of the program and the measurement that has been used for assessment of coverage. Next slide. When EPI was founded in 1974, there was no immunization schedule and there was no measurement of immunization coverage. It took until 1980 to develop those measurements, and then it turned out it was only 20%. Most people had estimated over 50%. By 1984, they had doubled the coverage, and by 1989, Henderson and his team had improved coverage to about 75%. Next. I did participate in helping to establish a schedule in 1984 to give the antigens that were being administered as early in life as possible and as short of intervals as possible in order to get coverage for children in all countries, as well as giving tetanus toxoid to pregnant women. Measles vaccine had to be delayed until 9 months because of interference with maternal antibody. This schedule is no longer optimal, but it played an important role in helping assess programs. Next slide. Setting up EPI clinics in the villages and cities and towns throughout the world was an enormous undertaking. This is just but one West African village. I had the good fortune to visit several of these. They were unique experiences with social gatherings and very positive in all of the communities that I was aware of at the time. However, there were numerous other challenges, including wars and misleading information, such as we have today, even back in the 1970s and 80s. Next slide. Henderson developed the cold chain. Early assessments showed that, in fact, as much as half of the vaccine being administered in some villages was not potent because they hadn't been stored properly. Developed new refrigeration techniques and transportation techniques. Not time to talk about the details here. Next slide. Some areas are very difficult to reach. This is the northern areas of Pakistan and the Himalayas, where the village can only be reached over about a 3-month period of time. So only 2 clinics a year were held in these areas. Hard to get high coverage rates at all times. Next slide. In 1976, vaccines to prevent 6 diseases were implemented universally, with yellow fever being given in the yellow fever endemic areas. Since then, the number of antigens, the number of diseases that they're trying to prevent has expanded to 13 now. I didn't mention malaria here. That's a totally different story. Next slide. The dotted red line shows that average coverage that I mentioned earlier. The point to note on this slide is that the blue line is the coverage for high-income countries, the green line for low-income countries. Huge disparities in the ability to deliver these vaccines, which decreased with increasing time and improvement in the program. Next slide. Large part of that improvement is due to the initiative, the Vaccine Alliance, called Gavi, with all of the organizations mentioned on this slide contributing, but especially funding from the Bill and Melinda Gates Foundation. Next slide. Coverage now with DTP is 89%. It's going to be almost impossible to get to 100%, but it continues to improve. Next slide. Each of the antigens that have been added created new challenges, as Bill mentioned, and new stories and unique interventions that have led to marked improvement. The Hib vaccine in particular was important because it was the most common cause of meningitis and a common cause of pneumonia, sepsis, and cellulitis in virtually all countries where it was imagined, except for the meningococcal epidemics in West Africa. Next slide. At the beginning of the Hib initiative that Bill mentioned, work had been done by Matu, Santosham, and others to expand from the United States and Europe to many Latin American countries, but most of Asia and Africa were not using the vaccine. Next. By 14 years later, at the end of the Hib initiative, they had managed to get the vaccines introduced with good coverage in most of the countries of the world. Next. Combination vaccines were instrumental in expanding the Hib vaccine in particular, but also other vaccines. There's about a dozen combination vaccines that are being used. These are just a few examples. Next. Tetanus toxoid to pregnant women created unique challenges because there was no program, and many pregnant women in developing countries did not get prenatal care. And if they did, it was often one visit. Getting 2 doses in lagged behind the coverage for others. Administration of the vaccine to the pregnant woman leads to antibodies that got transported across the placenta and prevent, next slide, neonatal tetanus, which was almost universally fatal in developing countries. There were about 18,000 cases reported in 2000. We know that's a gross underestimate of the true mortality. By 2022, that was down to just a little over 2,000 cases. So it continues to be a rare cause of neonatal mortality. Next slide. All of the EPI vaccines save lives. We now have estimates of projected estimates of lives saved. Bill gave you the number for the entire program over the entire years. This formal estimate was done just for the years that are shown on this slide. Next slide. By because, and this was done with support from Gavi, so Gavi was started around 2000. They estimated 50 million deaths were averted between 2000 and 2019, and a projected 97 million deaths could be averted by 2030. They're well on their way to that, but there have been problems, as you are probably well aware of, in terms of political conflicts, wars, famines, and other things that continue to be huge challenges for the program. Next. EPI became a way for delivering other public health interventions, such as vitamin A in West Africa, which saves many millions of lives. Next slide. And bed nets to prevent malaria. Next slide. Kate O'Brien, the former executive director of IVAC, has become the director of the Department of Immunization, Vaccines, and Biologicals for WHO that now includes EPI, and she is helping WHO face all of these challenges. That's all I was going to say. We'll be happy to take questions later. Thank you very much, Bill.
Thank you very much, Neil, for providing that history, and we recognize that you were a key part of that history of the development of the vaccine schedules for the EPI program. We're now going to look, after Neil's overview, we're now going to look at individual vaccines that were not part of the original EPI schedule, but are so important in saving the lives of children. And we're going to start with Professor Matu Santosham talking about rotavirus vaccine. So Matu, over to you.
Rotavirus is a fairly new organism that's known to humanity. It was only discovered about 50 years ago by Ruth Bishop. Next slide. And before the discovery of rotavirus, if you look at the unknown row, it's only 88% were unknown causes of diarrhea. But then in 1974, after rotavirus was discovered, the unknown came down to 29%. Next. And the person who deserves the credit for that is Ruth Bishop. Here's a picture with her in Melbourne in 2019. To her right is Umesh Prashar, who has also contributed a great deal to this field. Next. What we realized soon after Ruth discovered the organism was rotavirus was a democratic disease. It caused disease whether you lived in the United States or developed world, or you lived in the poor countries. Water and sanitation did not reduce rotavirus disease rates. The only difference is in developing countries, because of lack of access to appropriate care, many more children died. And almost every child before the availability of rotavirus vaccines, before the age of 5, experienced an episode of rotavirus diarrhea. Next. I don't have time to go through all the vaccine candidates. The initial vaccine candidate was an RIT, single bovine strain, then the single simian strain, RRV, developed by Al Kapikian, and then came along the first licensed vaccine, TRRV, later known as RotaShield. Unfortunately, it had to be withdrawn, and I will talk about that a little later. And then the Rotarix strain by GSK, a single human strain, was licensed, and also Rotatech, vaccine developed by Merck Sharp and Dohme. It was a bovine human Rhizartan G1, G2, G3, G4, and P8. I had the privilege of evaluating all of these vaccines except Rotarix. And I can tell you it was a very frustrating experience to work, especially with the RotaShield. And after years of work, it had to be withdrawn. Next. The burden of this disease is enormous. Greater than 500 children die from rotavirus diarrhea every day. 37% under 5 diarrhea hospitalizations are due to rotavirus globally. These are 2013 data. And the percent under 5 rotavirus death occurring in Gavi eligible and low income countries is over 90%. So if we are going to control this disease, we have to make sure the vaccines reach the poorest countries. Next. The rotavirus also has a huge economic burden. If you concentrate on Bangladesh in the middle, treating one episode of rotavirus diarrhea can amount to 85% of the average family income. Can you just imagine the devastation that must have on the family? Next slide, please. This is an interesting study done by Samir Saha. He demonstrated that 1 in 8 hospital admissions were due to gastroenteritis, and 54% of them were due to rotavirus. The consequence of that was many children, like 1 in 4, who sought hospitalization for these chronic diseases like cancer or renal disease were turned away. And as a result, those children died. Next. Next. Yeah, this is the second generation vaccine, the modified generation, the second generation, the modified Generian approach. I don't have time to go into the details of how it was manufactured. It was called RotaShield, and it showed a lot of promise initially. You know, we did one of the studies on the American Indian populations, and in developed countries, it had a higher efficacy, but in developing countries, in American Indian population, at about 60%. Next. Unfortunately, we experienced a rare, and I emphasize the word rare, but a real association between intussusception and administration of RotaShield. Next. The US decided to withdraw its recommendation. There's been a lot of hindsight looking into that, whether that was the right decision or not. But given the political situation at that time, without efficacy data from Asia and Africa, there was no way we could introduce this vaccines into developing countries. And even though trials were considered ethical, it was felt that politically we could not continue this vaccine. So the vaccine manufacturer stopped, and this was a huge disappointment for many of us who were working in the field. And we were wondering if this is going to be the demise of rotavirus vaccine. And fortunately, because of the foresight of 2 manufacturers, Merck Sharp and Dohme and GSK, they were willing to invest a huge amount of money in order to do large trials, somewhere in the order of 60 to 70,000 kids per trial, because you needed a huge number of children vaccinated in order to rule out intussusception. Next slide, please. So the vaccines to the left, Rotatec and Rotarix, were licensed based on these large trials. And you can see in the high-income countries, both for Rotatec and Rotarix, the efficacy was about 90%. But I will point out, in the low middle-income countries, the efficacy was between 40 to 60%, for both Rotarix and Rotatec. But there was an association with administration of the vaccine, very rare association. I emphasize again, very rare, but it was a true association. Later on, 2 Indian manufacturers came on board, Rotavac by Biotech, which was they used a neonatal strain, and Rotasil by Serum Institute of India. They used a bovine human reassortant, G1, G2, G3, G4, and G9. Their studies were only done in developing countries like India and Niger, and their efficacy ranged from 36 to 67%. Next. Just concentrate on the right, the big dots. What I would like to point out is that even though the efficacy of the vaccine was only about 50% in the poorest countries, for every 100 vaccinated infants, we were able to prevent 4 cases of rotavirus diarrhea. Whereas in the middle and upper income countries, we could only prevent 2 per 100 doses. Next slide, please. So this is a very important study conducted by Umesh Prashar and her group at the CDC. This study demonstrated in Mexico and Brazil the benefit to risk ratio. For admissions per year, the ratio was 687 to 1. And for deaths, it was 267 to 1. Therefore, even though the vaccines did have an association with interception, there was significant risk-benefit advantage. Next slide. Eventually, in 2021, SAGE did come up with a recommendation that rotavirus vaccines should be included in all national immunization programs. Next. And in 2010, we formed the Rota Council because we realized that without active advocacy, this vaccine will not be accepted in the poorest countries. Next slide, please. We had expert advisors from 16 countries. Next. And we were charged with communicating the burden of the disease, delivering accurate information, and serving as an independent body, working to ensure that vaccines are seen as part of a comprehensive approach. Next. So by 2010, you can see the red is of low coverage. Even US had very low coverage. Next. 2012, the US still had low, not very low, but low coverage. By 2022, next slide, many African countries and Asian countries began to use the vaccine. So I'll end by last slide by saying 120 countries now use rotavirus vaccines, yet 36 million children still have access to rotavirus vaccine, and 140,000 deaths have been prevented from 2006 to 2019. I would like to end by next acknowledging the amazing group of staff from the IVAC who supported the Rota Council, especially Molly Saar, who played a huge role. Thank you very much.
Great, thank you very much, Matu. And I think you've highlighted the great progress in the development and use of rotavirus vaccines, but also some of the challenges, and that it's not always smooth and straightforward getting a vaccine into the EPI schedule, and particularly highlighting some of the safety issues and benefit to risk calculations, as well as the important role of advocacy. And we can come back to some of this during the question and answer. So we're going to now switch to my colleague, Professor Maria Knoll. And Maria is also going to tell us about some successes, I think, and some challenges with pneumococcal conjugate vaccine. So Maria, over to you.
Thanks, Bill. Hi, everyone. The bacteria pneumococcus causes severe pneumonia, meningitis, sepsis, as well as other serious illnesses in all ages, but particularly in the youngest children. Pneumonia is the top cause of death in children under 5 years of age globally, excluding neonatal deaths. And before pneumococcal vaccines were available, pneumococcus was responsible for about 1/3 of those pneumonia deaths. There were over 600,000 pneumococcal deaths every year, and over 5 million severe cases of pneumococcal disease in young children globally before vaccines became available. There are at least 100 strains, which are called serotypes of pneumococcus, but luckily only a small number of those cause most of the serious disease. Next. Pneumococcus has been a known cause of severe pneumonia for a long time. In fact, the first vaccines to prevent pneumococcal pneumonia in adults were being developed over 100 years ago. But those vaccines only worked in adults and not children. The first pneumococcal vaccine that worked in children was a conjugate vaccine and was licensed in 2000, almost 80 years later. It targeted the serotypes responsible for most disease in the United States, and the US was the first country to introduce it into their national immunization program. That first vaccine targeted only 7 of those 100 serotypes, but these were responsible for 50 to 80% of the severe disease globally, depending on where you lived. About 10 years later, higher valency PCVs that covered 10 and 13 serotypes became available, and those vaccines targeted 70 to 80% of all pneumococcal disease globally. And recently, even higher valency vaccines, 15 and 20 valent vaccines, have been licensed, and there are more coming that are in the pipeline. Next. Here we can see just how well PCVs worked in the US. This figure shows the incidence of invasive pneumococcal disease, or IPD, the most severe form, in children under 5 years of age before and after introduction of PCV. The 7-valent vaccine was introduced in 2000 with a catch-up campaign, and you can see how rapidly disease fell. The declines in disease plateaued eventually, and then the 13-valent vaccine became available in 2010, and disease fell even further. Fell in the United States by 90%. There's the number of countries that introduced PCVs over time by their income status. In blue, you can see the high-income countries that introduced PCVs, starting, of course, first with the United States in 2000. There was a period of low supply initially, and so not many countries could introduce PCV. But then after about 5 years, you see a rapid increase in PCV introductions in the high-income countries. And shortly thereafter, only about 5 years later, you can also see rapid uptake in the lowest income Gavi countries shown in gold. And this was decades earlier than what had been anticipated, because the cost to fully immunize a child in the US was over $200, which was not affordable for low and middle income countries. And many thought this was a problem that could not be solved, and that it would be decades before the poorest children would have access to these life-saving vaccines. But a dedicated effort of a project called the Pneumo-ADIP, which was conducted by a small team of people that later became IVAC, helped to change that. And Gavi's advanced market commitment was critical for this success. It promised to purchase vaccines for Gavi-eligible countries if manufacturers would supply PCVs at affordable prices, and vaccines that targeted at least 70% of IPD in those countries. This was the first time this mechanism was tried, and you can see how incredibly successful it was. And of note, the AMC mechanism was also used for COVID-19 vaccines. Next. These efforts were so successful that some Gavi countries began introducing PCVs even before many high-income countries had introduced. Next. Today, you can see how widespread PCV use is globally. 93% of countries worldwide have introduced PCVs or are planning to introduce, including all Gavi countries. Next. The decline in invasive pneumococcal disease that was seen in the United States was also seen globally in countries that had high coverage with PCV. The 10 and 13 valent PCVs that became available in 2010 targeted serotypes responsible for 70 to 80% of the IPD globally, and IPD due to those serotypes fell by about 96% in children under 5. And that reduced all IPD in those countries by about 60 to 70%, so that now most of the remaining IPD is caused by non-vaccine serotypes. Next. PCVs not only reduce disease in immunized children, but they also reduce transmission, and that reduced disease in their contacts, which reduced vaccine-type disease in all age groups. And here you can see the decline in IPD in adults over the age of 65 who were not vaccinated themselves, but just lived in countries that had strong infant immunization programs. This is good news for young children too who aren't immunized, but who live in communities with high immunization coverage because they are also being protected. Next. But we still have to address the remaining disease not covered by these vaccines. And many new products are emerging to help address that. I already mentioned the new 15 and 20 valent vaccines that just became available, which target 40 to 60% of remaining disease. And there are new products covering even more serotypes in the pipeline that target as much as 80% of the remaining disease. Next. However, one of the biggest remaining challenges we have is low vaccine coverage in countries that have already introduced PCV. It's estimated that 41% of children remain unvaccinated despite 86% of countries using PCVs, and much of that is due to low coverage. We also have to ensure that children who live in low and middle income countries will have access to those higher valency vaccines that are in the pipeline. Next. In summary, incredible progress has been made in reducing pneumococcal disease globally because of the extensive and rapid rollout of the highly effective pneumococcal conjugate vaccines. And we've seen that these vaccines protect more than just those immunized. By reducing transmission, they've also reduced disease in all persons living in their community, including other unimmunized children. Multiple vaccine manufacturers, including some in developing countries, help ensure a good supply of PCV for the whole world. And newer products are becoming available that target more and more of the remaining serotypes that cause disease. But we need to continue to make progress in preventing disease in the countries with the highest burden. And to do that, we need to ensure that vaccine coverage is adequate and that low and middle income countries will have access to the future higher valency vaccines. Thank you.
Great. Thank you very much, Maria. And I think we're hearing that there are challenges unique to each of these vaccines, unique to rotavirus vaccines, unique to pneumococcal conjugate vaccines, particularly the high number of serotypes as you described so well, but also common threads about increasing vaccine coverage, particularly in low and middle income countries and increasingly in middle income countries that have to finance the vaccines themselves. I want to point out to our audience that a number of the graphs and maps that you're seeing during these presentations are produced by IVAC and are on the IVAC View Hub website. So maybe we can put that in the chat, that link, so all of you can see the data across a large number of different vaccines. So we're going to have our last presenter, Dr. Chizoba Winoti, and she will be speaking to us about HPV vaccines. Chizoba, over to you, if you can put your camera on as well.
I'm going to be talking about HPV vaccine introductions across the world. Human papillomavirus or HPV vaccine is an infection that is common to men and women. It's one of the commonest sexually transmitted infections. Most people will get HPV infection once in their lifetime, but their bodies will spontaneously resolve the infection. There are more than 100 different types of the HPV, and then 12 of them are high risk in the sense that persistent infection with those types could lead to cancer. HPV infection that leads to cancer is one of the few cancers that we actually know the definitive cause of. Nearly all cervical cancers are caused by HPV infection. An infection affects both men and women, and they lead to oral genital cancer. So you can see in the slide here, you have, for both men and women, they can have HPV can cause throat cancer, it can cause anal cancer, cervical cancer. But cervical cancer is by far the strongest or biggest public health burden that HPV imposes. And another thing with cervical cancer is that it represents huge inequity in disease burden. So globally, there are around 600,000 new cases of cervical cancer diagnosed every year, according to WHO. And then when you consider age standardized incidence and mortality of cervical cancer, you can see that there is huge disparity at the regional level. East Africa, you can see in the graph on the left, is at the top with around 95% incidence rate per 100,000 in Eswatini. Compare that to less than 3% incidence rate of cervical cancer in regions of West Asia, Australia, and New Zealand. So about 90% of deaths from cervical cancer occurred in lower middle income countries. The good news is that there is a vaccine for HPV, which causes cervical cancer, and WHO has used this vaccine as well as other interventions to set out a strategy for the elimination of cervical cancer by the next generation. So there is the 90-70-90 strategy, where the goal is that by 2030, 90% of girls should be fully vaccinated with HPV vaccine by the age of 15, and 70% of women should be screened using a high performance test by the age of 55, again by age of 55, and then 90% of those identified with cervical cancer disease should receive appropriate treatment. One of the reasons for the high incidence of cervical cancer and the high death rates in lower middle income countries is the fact that cancer treatment and screening is unavailable to most of the populations in LMICs. So vaccine will help to address that inequality. I just want to show that there has been a lot of progress that has been made on the development of cervical HPV vaccines. In the first HPV vaccine was introduced in 2006 in the US. And then since then, more recently, 6 HPV vaccines have been licensed. There are 3 bivalent vaccines, 2 quadrivalent, and recently 1 nanovalent vaccine. And all vaccines are highly efficacious in preventing infection with the virus types, as well as in preventing precancerous lesions that lead to cervical cancer. On the right-hand side is a study from Australia. If you look at where the blue arrow is, you see that in Australia, after several years of use of the HPV vaccine, the incidence of precancerous cervical lesions have declined tremendously amongst girls younger than 20 years old. So the younger cohort of girls who had received the vaccine have lower incidence of precancerous lesions. The other thing to note is that the WHO recommends that the target age for HPV vaccination should be young girls because it is more effective amongst the young girls. HPV vaccine is also one of the most cost-effective vaccines. This data here shows results from Mongolia. When you compare the incremental cost-effectiveness ratios for different vaccines, for PCV, for rotavirus, for HPV, going by a government perspective, you see that HPV is estimated to have a cost effectiveness of $265 compared to PCV. Rotavirus has a higher cost effectiveness compared to HPV. But from a societal perspective, on the right-hand side of the box, you see that HPV has the higher cost effectiveness, incremental cost effectiveness ratio. So in terms of global introduction, recall that I said that in 2006, that was the first time HPV was introduced in the US. Over time, more countries have introduced. Currently, there are 137 countries that have introduced the vaccine. And this slide is also from the IVAC View Hub, one of the resources that IVAC makes available to the global community. You will also see that there's, while a huge number of countries have introduced, there's still a number of countries that have not yet introduced, 32 of them, and many of these countries are in lower lower middle-income countries that don't have Gavi support, as you can see from the map here. I just wanted to round up by saying that WHO has recommended the schedule for HPV introduction. For girls 9 to 15 years, 1 or 2 doses are recommended. For girls 15 to 20, 1 or 2 doses are recommended. And then women older than 21 years, they recommend that 2 doses with the vaccine with 6 months interval. And then girls who have HIV infection, who are immunocompromised, should have a minimum of 2 doses or 3 doses when feasible. Now, the global coverage of HPV has been quite low compared to when it was introduced. And the COVID vaccination, the COVID pandemic actually affected the coverage rates. Gavi and other global partners have an effort to revitalize HPV programs across the countries, across different countries. So Nigeria is one of the countries where this revitalization effort is yielding fruits. Nigeria last year introduced the HPV vaccine single dose into the country using a 2-phase approach. IVAC is supporting the rollout of this vaccine in Nigeria by training and engaging civil society organizations to support the sensitization and communication that needs to happen at the community level for vaccine acceptance to occur. So far, IVAC has trained more than 200 civil society organizations who have then gone on to train more than 20,000 community-based vaccine champions who are supporting the rollout effort in Nigeria. So the first phase of the rollout in Nigeria was successful. Nigeria achieved more than 80% coverage of the vaccine in the target age group. So the rollout was using a multi-age cohort where girls 9 to 15 years were eligible. In this slide, you will see the coverage rates by different states. And one interesting point here in this slide is that Lagos State, which is one of the southern states that has typically had high coverage of all immunizations, childhood immunization, is showing the lowest coverage rates. And some of the reasons for this had to do with the pace of introduction during the campaign, as well as potentially vaccine hesitancy. So vaccine hesitancy is something that we need to continue to be vigilant about because it might strike in the most unexpected places. So in summary, I have presented that HPV is a major cause of cervical and other anogenital cancers globally, with 90% of deaths occurring in low and middle income countries. Despite the vaccine introduction in over 137 countries, the global coverage still stands at 21%. So there is a lot that needs to be done to ramp up coverage, especially during the routine program in different countries. And some of these efforts include optimizing school-based delivery campaigns, integrated delivery of HPV, and catch-up initiatives. IVAC supports countries with technical assistance, advocacy, capacity building to improve coverage and address challenges related to misinformation and access of the vaccine. Thank you very much.
Thank you, Dr. Winoti, for that great summary of HPV vaccine and the scale up. We have 10 minutes for comments and questions from the audience, and so please use the Q&A feature on Zoom. I'm going to ask our panelists if they could put their camera back on. We have some questions in the Q&A, and I'm going to try to direct some of these. I think what we'll do is we'll take some of the vaccine-specific ones first and then come to some of the higher-level questions. But maybe, Professor Santosham, I'll start with you. There was a question on the differences in vaccine efficacy in low and middle income countries that you showed for rotavirus vaccine and high income countries, and what might account for those differences?
The short answer is that we don't know, but there are several hypotheses. One is, the leading one is that the infection load is so high in a developing country setting. And also transmission rates may be higher. I personally don't buy that. That's one of the hypotheses that's been put forward. But the answer is we don't know.
Yeah, okay. An area for research, further research. There's a question, Maria, if you, I think you may be typing an answer, but if you could address the question about the number of doses of PCV that are needed, and I know you're very much involved in research looking at different or alternative schedules for PCV vaccine. So maybe you could talk a little bit about that.
Yeah, thanks for that question. I think a lot of the questions about scheduling now is how do we reduce the number of doses in countries that have been using them for a long time if these diseases, due to these serotypes, are essentially almost gone. Do we need to have as many doses? So that's a question that's currently being explored right now. And the UK has introduced a 2-dose schedule, 1 priming dose and 1 booster dose. So everybody is watching to see how that goes. But this question was about the need for booster doses at all. And there's countries that have trouble implementing a booster dose schedule. And can you just give doses earlier in life during the EPI time period? And yes, you can. The WHO recommends either 3 primary doses without a booster or 2 primary doses with a booster. So 3 doses at least for countries that are rolling out these vaccines. And so there is that option. When we look at the data, and it's hard to get precise data, but Australia monitored this very carefully because they had a 3-dose schedule, and they found breakthrough infections in toddlers. So children who were over 18 months of age, there started to be a couple of cases of 19A and 19F disease in vaccinated children. And with implementing the booster dose, those go away. So the booster dose is important, but it works great with 3 doses if you can't do a booster dose.
Great, thank you, Maria. There are a couple questions, Chizoba, about acceptability and demand of HPV vaccine, given that this is now a childhood vaccine, adolescent vaccine, and it's for a sexually transmitted infection. And I know that's a large, complex question, but if you could just reflect a little bit on your experience perhaps in Nigeria in addressing that issue. How do the advocates kind of pitch this vaccine?
Thank you. That's absolutely true. The association between HPV as a sexually transmitted infection can be a challenge for parents. So what we do with our advocates is we don't dwell on the idea or the fact that HPV is a sexually transmitted infection. We do say it, but when we focus on the idea that it's a cancer-preventing vaccine, and by the time we have a dialogue with whoever is hesitant about it and really focus on the cancer prevention benefits of the vaccine, I think we're able to overcome the reluctance. But it is true that many parents, even here in the US, that kind of shy away from giving their daughters the vaccine because of the association with sexually transmitted infection of the virus.
Great, thank you very much, Chizoba. Neil, you mentioned in your talk the fact that there was misinformation about vaccines going back to the probably the beginning of the EPI program. And there's a question around vaccine hesitancy and that as a problem. But I wonder if you could reflect a little bit on that, given your kind of historical knowledge of the EPI program and specifically vaccine safety issues.
I would say that safety issues have been predominant in terms of leading to vaccine hesitancy. Misinformation has been there from the beginning. As an example, I was involved in helping counter some of the misinformation about tetanus toxoid in pregnancy. There was confusion with administering injections to women to prevent pregnancy. Depo-Provera was given by injection, and there were members of predominant church groups who were opposed to that, and they came out opposed to tetanus toxoid to prevent it. We had to intervene. I say we, but I did a little bit. Others did much more to help convince those religious leaders that that was just not the case. There was no problem with that. We have misinformation about measles vaccine and causing a variety of diseases, both in developing and developed countries. In developed countries, the hypothesis that measles vaccine and MMR in particular could contribute to autism was a huge problem going back 20 years ago, and still persists in some people today. That's been appropriately countered, but still the myths persist. The other problem, especially in the United States and also now in Europe, is the politicization of vaccines and the anti-vaccine movement. And that stemmed in part from some leaders in the United States in our Congress who actually had relatives with autism and taking up the charge that vaccines, cause autism. And that's been expanded to other political leaders. And I'm not going to go into details. It is in the United States. It's also in Africa and somewhat in Latin America. All I can say is we have to maintain vigilance. We have to continue to counter them. And it takes more than just the factual information. I'm pretty decent about dealing with the factual information, but how people come to make these decisions and who's the source of the information is a subject of ongoing research and development of intervention programs. But it's a never-ending struggle that I think will continue through all of our lifetimes.
Great. Thank you very much, Neil. And I know we're coming to the end of the hour. There are a number of other questions in the Q&A, and perhaps we can try to save those and address some of them. But I want to thank all of our panelists for their excellent presentations. We realize each of these topics could be an entire hour, if not longer. So we're really kind of scratching the surface here. But I think what we've heard the history of the EPI program and the great advances that this has made over the past 50 years. And then we've heard about 3 vaccines that weren't part of the original EPI program, but that have been introduced after really decades of research and work that has gone into this. We're beginning to see the benefits. We are seeing the benefits of these 3 new vaccines, but there's still more work to do to be able to increase coverage with all of the EPI vaccines and vaccines throughout the life course, and addressing some of the issues that Professor Halsey just acknowledged, is going to be a big part of that. But there are certainly other aspects, improving the primary healthcare systems that are capable of delivering these. Someone mentioned the shortage of cholera vaccines, making sure that we have adequate supplies of vaccine, and making sure that we, on the demand side, have the trust of the communities in which we work. So I want to thank all of you for participating. Again, this webinar is being recorded, and we will share that recording when that is available. So thanks to all of you.